Hi, and welcome back to the Pro-PA Podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling pulmonic valve disorders, pulmonic stenosis, and pulmonic regurgitation. While these conditions are less common compared to other valvular diseases, understanding their presentation, diagnosis, and management is still important in primary care. Let's break it all down. We'll start off with pulmonic stenosis and then discuss pulmonic regurgitation secondly. Pulmonic stenosis is a congenital or acquired narrowing of the pulmonic valve, leading to obstruction of right ventricular outflow. This increases right ventricular pressure, causing hypertrophy, and in severe cases, right-sided heart failure. Who does it affect? It is most commonly congenital and is often diagnosed in childhood, though mild cases may remain undiagnosed until adulthood. Risk factors include congenital syndromes like Noonan syndrome or tetralogy of Fallot. The clinical presentation is commonly asymptomatic during mild to moderate disease, but in severe pulmonic stenosis, it presents with exertional dyspnea, fatigue, syncope, and anginal chest pain, which is from oxygen supply and demand mismatch. On auscultation, you will hear a systolic crescendo-decrescendo ejection murmur, which is best heard at the left upper sternal border. The murmur is preceded by a pulmonary ejection click, which decreases with inspiration, and a wide split S2. It's important to note that this is the only right-sided murmur that decreases with inspiration. And in severe cases, signs of right-sided heart failure, such as jugular venous distension, peripheral edema, hepatomegaly, and ascites may be present. The diagnosis can be made with an echocardiogram. It assesses valve morphology, pressure gradients, and right ventricular function. The management depends on valve anatomy, severity, and symptom status. Mild and asymptomatic cases require periodic monitoring with electrocardiogram and echocardiogram. Diuretics are indicated for right ventricular overload, and moderate to severe cases may require balloon valvotomy, which is the preferred treatment. Surgical valvotomy may be preferred or required if the balloon valvotomy is unsuccessful, anatomy is not favorable, or if patient is having cardiac surgery for another indication. Now, although there are no specific preventative measures for congenital pulmonic stenosis, early detection allows for better long-term outcomes. All right, now let's talk about pulmonic regurgitation. This occurs when the pulmonic valve fails to close properly, allowing blood to flow back into the right ventricle during diastole. This can result from primary valve disease or secondary conditions such as pulmonary hypertension, endocarditis, or prior surgical interventions to a stenotic pulmonic valve, leading to right ventricular dilation and eventual dysfunction. In contrast to pulmonic stenosis, pulmonic regurgitation is more frequently diagnosed in adults, and the median age at diagnosis is 77 years of age. As far as clinical presentation, pulmonic regurgitation is frequently asymptomatic during mild to moderate disease, but may present with fatigue, exertional dyspnea, palpitations, syncope, or signs of right heart failure, such as jugular venous distension, ascites, peripheral edema, and hepatic congestion. The classic murmur of pulmonic regurgitation is a high-pitched, decrescendo diastolic murmur heard best at the left upper sternal border, which becomes more prominent with inspiration and diminishes with Valsalva maneuver. As far as diagnosis, an echocardiogram is also the test of choice for pulmonic regurgitation. And as far as management, patients with pulmonic regurgitation need annual exam and echocardiogram. Pharmacologic therapy is not needed if patient is asymptomatic, but if patient presents with associated heart failure, then diuretics and ACE inhibitors can be used. In the case of secondary pulmonic regurgitation, medical therapy should be directed at the underlying cause, such as pulmonary arterial hypertension or carcinoid disease. And lastly, symptomatic and/or severe pulmonic regurgitation requires surgical or transcatheter pulmonic valve replacement. Preventing pulmonic regurgitation involves managing underlying conditions such as pulmonary hypertension or endocarditis. Alright, before we get some practice in, here are some clinical pearls. Number 1. A systolic ejection murmur with a click at the left upper sternal border suggests pulmonic stenosis. Number 2. Balloon valvotomy is the preferred treatment for pulmonic stenosis. Number 3. Pulmonic regurgitation is often secondary to pulmonary hypertension and may present with a diastolic decrescendo murmur. Number 4. Symptomatic and/or severe pulmonic regurgitation require valve replacement. And number 5. Echocardiography is the diagnostic test of choice for both conditions. Alright, here are some clinical questions. Question 1. A 30-year-old woman is evaluated for exertional dyspnea and fatigue. She has no significant medical history. On exam, you hear a crescendo-decrescendo systolic ejection murmur preceded by an ejection click at the left upper sternal border. There is also a wide split S2 present. Which of the following is the most likely diagnosis? Is it A. Aortic stenosis, B. Mitral regurgitation, C. Pulmonic stenosis, or D. Tricuspid regurgitation? I'll give you a couple of seconds. If you chose C. Pulmonic stenosis, you are correct. The presence of a systolic ejection murmur with an ejection click at the left upper sternal border and a wide split S2 strongly suggests pulmonic stenosis. Aortic stenosis would be best heard at the right upper sternal border, and mitral or tricuspid valve abnormalities typically present differently. Question 2. A 45-year-old man with a history of repaired tetralogy of Fallot presents with fatigue and exertional dyspnea. Physical exam reveals a diastolic murmur at the left upper sternal border that increases with inspiration. Echocardiography shows severe pulmonic regurgitation with right ventricular dilation. Which of the following is the next best step? Is it A. Observation with annual follow-up, B. Pulmonary valve replacement, C. Diuretic therapy alone, or D. Balloon valvuloplasty? If you chose B. Pulmonary valve replacement, you are correct. Severe and symptomatic pulmonic regurgitation requires valve replacement. Observation is inappropriate given the severity, and balloon valvuloplasty is for stenosis, not regurgitation. Great job! That wraps up today's discussion on pulmonic stenosis and regurgitation. While these conditions may not be as common as other valvular diseases, recognizing their presentations and knowing when to refer is crucial for practicing PAs. Thanks for tuning in. Don't forget to subscribe to the Pro-PA Podcast for more cardiovascular episodes. And as always, this is the Pro-PA Podcast, where future pros in medicine are made. See you next time.